Now I'd like to go to Dr. Maury Gertz. Um, I've been working in myeloma now for 22 years, and Dr. Gertz was the person who explained myeloma to me. Once I heard him speak, I got it. And people constantly ask me, if you were diagnosed with myeloma, where would you go? And I never give them that answer, but I tell them one thing. I said, the first person I would go see is Dr. Gertz, because not necessarily for treatment, but he would be able to explain to me what I needed to know better than anybody. And so with that, I know that Dr. Gertz, I know you've been doing a lot of research on COVID and myeloma. I know that you've got a paper that has either to be published or has recently been published, but I did see the manuscript. So could you take this time to give us a sense of what you know about myeloma and cancer, myeloma and patients and COVID today, and what your recommendations are moving forward, and what are the known unknowns that you focus on?
Very good. Nice to see you again, Greg, and hello, Sundar and Matt. Good to be with you on this conference. Just a little background. Minnesota is not New York in terms of population density. We're half urban, we're half rural. Olmsted County, Minnesota. Well, I'll start with the state of Minnesota. The state of Minnesota has had 2,200 patients diagnosed. We're a state of 5.5 million. So it's about one person infected for every 2,500 population. And the state has had 121 deaths, so a case mortality rate of approximately 5%. Olmsted County, Minnesota, which is where the Mayo Clinic is, and probably 3/4, 2/3 of the people who live in the county work at Mayo or some Mayo subsidiary. And so therefore it's quite enriched in healthcare workers, has had 113 cases for a population of 100,000, 170 for a population of 100,000, or about one person in 600. So we're running fourfold infection rate compared with the rest of the state. In the county, however, of the 1 in 600, we've only had 2 deaths. So the case mortality rate, therefore, is about 1.5%. And the 2 patients who died were 84 and 90 years old, one of whom was in a nursing home, both of whom had pre-existing conditions. So we're not running the epidemic levels that are reported in some of the hot zones. Nonetheless, we've done what every other large medical center has done. Right now, stem cell transplant is absolutely at a complete standstill for myeloma patients. And patients who are not relapsing, who are stable, or continuing their induction chemotherapy, no one's going to transplant. Celgene, the makers of pomalidomide, Pomalyst, and lenalidomide, Revlimid, have relaxed their rules. It used to be that they could only dispense 28 days at a time. Now they're allowing 56 tablets to be dispensed at a time. So for patients who are on all oral therapy, we're moving their visits now out to once every 8 weeks. We've done a lot of what Dr. Jagannath has said. If patients were receiving bortezomib, Velcade, we've moved them to ixazomib, Ninlaro, so they can move to oral regimen. So we're using a lot of ixazomib, lenalidomide, Revlimid, dexamethasone. So it's all pills, and it's only one visit required every 4 weeks, although we're trying to have them have their blood drawn locally at the closer lab rather than at a population dense Mayo Clinic. And then we will video conference and phone conference. So we are fully set up now to do consultations, both for future transplant or for relapse or diagnosis, using outside records and then video conferencing, just like I'm doing now, at a patient's home or by the phone. Patients who are receiving daratumumab or Darzalex, if they're receiving it weekly, we've moved it to every 2 weeks. If they're getting it every 2 weeks, we've moved it to every 4 weeks. And based on how long patients have been on therapy, how well their control is, we've been pretty lax. We've been delaying resumption of therapy. If they do it 4 weeks, we're letting it go if they've been in a stable plateau for some period of time. And so transplant is done. We're favoring oral therapies and we're delaying. So if someone was getting subcutaneous injections of bortezomib, Velcade every other week, we're moving that to every 4 weeks. So everything is trying to minimize exposure with our healthcare center. Our waiting rooms have been moved for social distancing. Chairs have been removed from the lobby so people can't sit close to one another. Uniform masking for all healthcare personnel in the outpatient. Visitors aren't allowed in the hospital. Inpatients, both admissions, all are COVID screened. Any patient coming for chemotherapy is COVID screened. Greg started out by asking about multiple myeloma. Oh, I should say the state of Minnesota. No, I said state of Minnesota. Asked about myeloma, and here's the issue. Myeloma is a disease of the cells that make antibody proteins, the protective proteins that treat infections. And so we refer to these antibody proteins as immunoglobulins. And almost all myeloma patients don't have functioning immunoglobulins. Some patients prior to the epidemic, due to recurrent infections, might be receiving intravenous immunoglobulin injections. That's to replace the loss of antibodies that their body normally suppresses. But the myeloma cell replaces the normal antibody producing cells of the body. So there's this unique lack of antibodies that makes, I think, the myeloma patient far more predisposed. In addition, there are certain medicines, Darzalex or daratumumab particularly, where you clearly see an increased risk of upper respiratory infections. That's unequivocal. And then the other medicines can have an effect on the white blood cell count and lowering your body's resistance that way when you're on continuous therapy. And so there are multiple facets where myeloma patients are uniquely predisposed to develop complications, and we're quite concerned about it. Actually, from my own personal population, one of the bothersome things is I have a firefighter who's now on maintenance treatment with Darzalex and Ninlaro, who developed a fever, as did his wife, lasted about 8 days. But we swabbed him 2 weeks later. He was still positive, so we delayed him coming. We swabbed him again 3 days later, which was yesterday, and he's still positive. So even at 17 days, he hasn't cleared the virus. And so it's getting me a little nervous about this 14-day self-quarantine. It's not so easy for me to know where the 14-day came up with, because at least in this one instance, he's persistently positive. The virus hasn't cleared, and so we're keeping him in quarantine. We're not letting him out while we know he's continuing to be positive. And any COVID positive patient isn't allowed near our institution. They can't access the chemotherapy unit. Every individual who comes into the Mayo Clinic building we've got 80% of the doors locked, so there are only 2 entrances now. And they're questioned about cough, shortness of breath, fever, exposure to someone who has a positive, and then they have their temperature taken, and then they get a sticker that they put on their lapels with the day of the week. It's a different color every day. So when they're walking around, you can look and see that patient has been screened. And if they come back the next day, they have to go through the same process to get a new sticker with the new day and a new color on it. And so those are some of the precautions. But even with this, we've flattened out in Minnesota, and we're beginning to discuss reactivation of the practice based on need. So that patients that we would consider urgent, which in a myeloma setting to me would be relapsing disease, those patients are given access for face-to-face consult. Less urgent patients are done by phone or video conferencing. And so far, For the patients that we're screening, we're doing, I think, a credible job in preventing transmission of the infection. I'll stop there, Greg, for additional questions you might have.
Sure. What about how, we see so much in the news about opening dates, about when things will get back to normal. Do you pay attention to that? And just give me your sense of that. So yesterday, for example, the beaches opened up in Jacksonville, Florida, and there were a lot of people out there. What, from your medical point of view, what does that make you think?
I don't think we have the infrastructure to make the decision. I think the big question on everybody's mind is how many people are carriers of the virus who have no symptoms at all. So if you want to just look at popular media, George Stephanopoulos became positive for coronavirus. He caught it from his wife. And so he put himself in self-quarantine. However, George Stephanopoulos had no symptoms at all, nothing. He had some lower abdominal pain, hard to know, but he had none of the typical symptoms of cough, fever, runny nose, sneezing, and he was infected. And here's the problem then. How many people on the beaches feel great are carriers of the virus? I wouldn't let my myeloma patients visit Jacksonville Beach out of concern. And so then the question is, well, then if we're going to start talking about opening up, don't we need to know how many people actually are carrying the virus who are not simply recovering, but were not symptomatic in the first place? And right now, the state of Minnesota is looking to test 4,000 people a day, 30,000 people a week, and we're a relatively small state, and we don't have that capacity yet. But until we have the capacity to know how many people at the beach, at Macy's, at Walmart are walking around feeling great with the virus, I think it's pretty difficult to make a evidence-based decision about when we're supposed to reopen the economy.
Right. And I think one of the things, there were so many people out of work. And what I find, I feel fortunate to be working, but I find myself working harder than I ever have. I feel, even though I'm at home and I don't commute back and forth and all of that. What's a typical day like for you in terms of how you interact with patients, how you see people in the clinic, and how you keep your mental health?
Right. I think part of the problem is that there's no activity other than going to work and sitting at home. There's nothing in between for me. Last weekend, Saturday, my activity consisted of going to get the mail. That was it. I was in the house and I got the mail. Then last Sunday, Minnesota, it snowed 7.5 inches. And so I plowed myself to the foot of the driveway. That's as far as I went, the foot of the driveway. Otherwise, I'm inside streaming video on Netflix and going crazy. There really isn't. This is a welcome diversion. I'm thrilled to be on a video conference seeing friends because it gives me something to do other than watch old movies. And there is a mental health issue here. I'm not really living in fear of getting the virus. Life, as far as I'm concerned, is on hold. And I think nationally we're facing this chronic tension. And that tension is between individual liberties and societal responsibilities. I'm watching protesters in Michigan saying, you have no right to keep me quarantined. I need to be out and about. And I think, well, where's your sense of responsibility to the rest of the population? People who, if you're a myeloma patient and a vaccine was available, I'm not convinced that you're going to respond to the vaccine. And so we need to be certain that everybody else gets vaccinated so that the vulnerable populations that either can't receive a vaccine or it's uncertain whether they'll respond to a vaccine benefit from, if you will, the herd immunity. And so I think that the reason to stay home isn't just, even though it's a financial burden, isn't just I'm feeling well and I'm bored. It's because I'm worried about all of the other people in my city, county, state that I may be responsible for infecting. And I think there's some level of irresponsibility when individuals disregard the governor's orders in their respective states. They have all the data to know when it's right to reopen and say, yeah, I'm out there, I'm going to go to the funeral, the church, to my kid's basketball game, have a party at the house, invite 20 or 30 people. I think it's very irresponsible.
And I also, you love to read history, you love to read, and I've been rereading John Barry's book about the Great Influenza of 1918. And the one thing, as I compare that was, yes, it was bad, but it was a different time. We know so much more today about how to deal with hygiene and things like that than they did back then. There's a lot more openness and communication today than there was back then. But one of the things that I hear a lot, and one of the points that comes up in that book, is that there was a lull by the spring of 1919. Everybody thought this was over, and people got back to their lives. And then in the fall of 1919, it came back with a vengeance. Do you fear that? And if so, why? And if not, why not?
So we have a lot of data because Mayo Clinic was open in 1918. The Mayo brothers were alive and doing surgery and caring for patients. So those records exist during it. And in fact, the Mayo brothers were commissioned officers in World War I. And so we did have capacity for managing the influenza pandemic. A couple comments. Keep in mind, at that time, it was known that bacteria existed. Viruses were not known to exist. The particle of transmission was completely unknown. But of course, the real problem, because it was during the demobilization of World War I, we still had very large barracks that housed thousands of soldiers and infantrymen. And that was really, they didn't practice social distancing. That concept didn't exist. And as a consequence, the lack of social distancing, the clustering was responsible. In addition, people lived a lot closer together in the cities in those days because there wasn't much in the way of public transportation or cars. So most people had to walk to work. They needed to live relatively close. And so that packed people into apartment buildings in poor areas. They'd be called tenements. And so it facilitated spread. And so this issue about what to do about it wasn't very clear. And of course, there were no vaccines, no antibiotics to treat secondary pneumonia, no antibodies to treat cytokine release syndrome when you got respiratory distress syndrome from coronavirus or influenza virus. And so it was very different. But the big piece here is that the case mortality rate for influenza today is about 1 in 1,000. And nationally in the United States, it's about 1 in 50. And so even though influenza actually at that time was actually greater than coronavirus is now, the fact that the number of patients dying who were infected was much, much greater. And this appears based on what the published cell phone data is. The transmissibility of this virus appears to be greater than influenza. And that explains why you got 50 people on a cruise ship who get infected out of a few, and then you've got this naval military vessel where the captain was fired trying to get resources, and you've got over 150 infected on that ship. So, and that just goes to how easy this virus somehow latches on and infects people.